Good evening. My name is Antonio Rayford. I am a third-year Doctor of Pharmacy candidate from Mobile, Alabama, and I will be presenting my journal club this evening on the comparison of Pregabalin and Pramipexole for restless leg syndrome. This journal has several authors, which include Richard P. Allen, Crystal Chen, Diego Garcia, Ali Polo, Sarah Dubray, Jeffrey McKellar, Lloyd Knapp, and John W. Winkleman. This journal was funded by Pfizer, and there are several citations which will be submitted with the email. A quick background on this journal. Basically, the dopaminergic medications relieve medicines of restless leg syndrome, or RLS, which you'll see throughout the journal, but have the potential to cause heterogenic worsening augmentation of RLS with long-term treatment. Pregabalin may be an effective alternative. The methods for this research. In the 52-week, the methods and the objective for this journal. In the 52-week randomized double-blind trial, we assessed efficacy and augmentation in patients with RLS who were treated with Pregabalin as compared to the placebo and Pramipexole. The trial design. Patients were randomly assigned to receive placebo 0.25 milligrams of Pramipexole per day or 0.5 milligrams of Pramipexole per day or 300 milligrams of Pregabalin per day for 12 weeks in capsules that were identical in appearance. After which, patients receiving the placebo were randomly assigned to one of the three treatments for the remainder of the study. The medication doses were increased over the first 2 weeks of the study and a final fixed dose. The Pregabalin dose was based on the results of the study and to the final fixed dose. The Pregabalin dose was based on the results of the medications for at least 1 week of five half-lives, which were longer. This period was followed by a 1 week single blind placebo run-in. Thus, all study participants discontinued their RLS medications at least 2 weeks before starting the medications. Medication was administered orally 1 to 3 hours before bedtime. The use of containment RLS medications were not allowed. Visits were scheduled at the start of treatment and at 2, 6, 10, 12, and 14 weeks after the start of treatment. Thereafter, until the end of the study, 52 weeks from the start of the treatment. Visits were monthly, and patients also completed daily logs of symptoms during the week preceding each visit. At the end of the study, the review board evaluated possible causes of augmentation by reviewing double-blind information consisting of entries from patients' logs, efficacy augmentation data compiled by clinicians. The determination of whether a case qualified as augmentation was based upon the unanimous agreement that the established criteria had been met. This review was performed before the study. The group assignments were revealed. And the location of this journal was in the United States and in Europe. And the approval was it was approved by the institutional review boards of participating institutions. The inclusions for this study or this journal. The adults had to be 18 years of age or older, moderate to severe primary RLS, symptoms occur at night, symptoms onset 6 months before diagnosis, symptoms present at night 15 plus days before diagnosis, RLS score of 15 or higher at the beginning and end of week 1 placebo runs. The exclusions for this journal, basically there was just one, and it was prior report with augmentation. Now, the subject for this journal include the patients with restless leg syndrome or RLS, and the primary endpoint there was 4. There was a comparison of Pregabalin with placebo, change from baseline to week 12 in RLS score, patients with a CGI evaluation of much improved symptoms, 4, change from baseline to week 40 or week 52 in percentage of participants with augmentation as defined above. The secondary endpoints for this journal include Patient-reported measures included limb pain and assessed on visual analog scale, quality of life with RLS and assessed on questionnaire, sleep as assessed on subjective sleep questionnaire. At each study visit, participants were asked to complete the Columbia Suicide Severity Rating Scale for suicidal behavior. The follow-up. Visits were scheduled at the start of the treatment at 2, 6, 10, 12, and 14 weeks after the start treatment, and then to the end of the 52-week treatment. The comparison of the Pregabalin and the placebo over the 12 weeks was based on the International Study Group Rating Scale, and the comparison of Pregabalin and Pramipexole over the 40 to 52-week period, assessing improvement of symptoms through a clinical global impression of global improvement scale. Comparison of Pregabalin and Pramipexole over a 40 to 52-week period, assessing augmentation of RLS. The duration. This study took place between December 2008 to June 2011. The population from which this came from was a total of 719 participants received daily treatment. That was the total. So 182 with 300 milligrams of Pregabalin, 178 with 0.25 milligrams of Pramipexole. Then you had 180 on 0.5 milligrams of Pramipexole, and then you had 179 on the placebo. The arms for the journal. The control group, placebo. The intention to treat population was Pregabalin 300 milligrams, Pramipexole 0.25 milligrams, and Pramipexole 0.5 milligrams. The statistical analysis. Step 1, the Pregabalin versus placebo for RLS score over a 12-week period. Step 2, Pregabalin versus placebo for the CGI evaluation over a 12-week period. Step 3, Pregabalin versus 0.5 milligrams of Pramipexole for augmentation over a 52-week period. Step 4, Pregabalin versus 0.25 milligrams of Pramipexole for non-inferior efficacy based on the IRS score over a period of 12 weeks. Step 5, Pregabalin versus 0.25 milligrams of Pramipexole for non-inferior efficacy over a period of 52 weeks. Step 6, 7, and 8 all are inclusive with the Pregabalin versus 0.5 milligrams of Pramipexole for non-inferior efficacy over a period of 12 weeks. Now, the only difference was in step 8 that it was 0.25 milligrams of Pramipexole for augmentation over a period of 52 weeks. The baseline for this study are the results. The characteristics of the patients at baseline and treatment completion rates were similar across study groups. The primary endpoint. After 12 weeks, patients who received Pregabalin as compared to those who received the placebo had significant greater reduction improvement in the RLS score, and a greater proportion of patients in the Pregabalin group had symptoms that were reported as a very much or improved the CGI evaluation from 71.4% versus 46.8%, which is a very large difference. And it had a p-value of less than 0.1. And as we know, the higher the p-value means it's less likely to be by chance. So the second primary endpoint, as compared with placebo, the 0.5 milligram dose of Pramipexole, but not the 0.25 milligram dose, was associated with a significant reduction in RLS score and significantly greater proportion of patients with improvement on the CGI evaluation. 3. Pregabalin had less augmentation compared to Pramipexole at a dose of 0.5 milligrams, but not at a dose of 0.25 milligrams per day after 52 weeks. The secondary endpoints for this journal, evaluation of secondary outcomes for active treatments are compared with placebos after the 12 weeks, while outside of the step-down testing procedure and statistical significance. And that was not excess. Greater improvement in several measures of the sleep with Pregabalin than either Pramipexole, including waking after sleep, onset quality of sleep, number of awakenings, and total sleep time. In contrast, a reduction in time it took to fall asleep was pronounced with both doses of Pramipexole versus the placebo than with Pregabalin versus the placebo. There were a few adverse events that took place with this. With Pregabalin, the most common adverse events was dizziness, somnolence, which is sleep, excessive sleep, fatigue, and headache. Pramipexole was had the most common events that included headache, nausea, and fatigue, which are typical adverse effects or side effects that you would see with most drugs. The rate of the study discontinuation was due to the adverse events that were lower in groups receiving Pramipexole, other than that receiving Pregabalin, which was 27.5%. 4. Adverse events leading to the study discontinuation. The most common events were somnolence, dizziness with Pregabalin, nausea, and headache with Pramipexole. Over 50 serious adverse events occurring during the treatment were reported in 37 patients. 11 of those receiving Pregabalin, 20 receiving 0.25 milligrams of Pramipexole, and 12 receiving 0.5 milligrams of Pramipexole. 5 events among patients which switched from placebo to Pregabalin, and 2 events among those who switched from placebo to Pramipexole at the dose of 0.25 milligrams. There were 11 cases of suicidal ideation. 6 in the group were receiving Pregabalin, 3 receiving 0.25 milligrams of Pramipexole, and 2 were receiving 0.5 milligrams of Pramipexole. These included 1 case involving preparatory acts towards imminent suicidal behavior in the patients receiving Pregabalin. 1 death was reported, a stroke in a 77-year-old woman receiving the Pregabalin. In the conclusions, the author's conclusion of the journal was basically it assessed the study and the primary endpoints showing that 300 milligrams of Pregabalin per day as compared to the placebo significantly improved the RLS treatment outcomes over the 12 weeks. Significantly less augmentation at doses of 0.5 milligrams of Pramipexole per day, but not those of 0.25 milligrams of Pramipexole after the 52 weeks. Treatment with Pregabalin was not superior to treatment with 0.5 milligrams of Pramipexole, and Pregabalin was associated with lower rates of nausea, vomiting, and headache than Pramipexole, but with higher rates of suicide ideation, dizziness, somnolence, and weight gain, factors that may limit its long-term use. Some of the streaks of this journal was that it was a good study with several reasons. The organization of the study allowed for easy assessment and understanding. It was very easy to read and it was very fluent. The population being studied was explicitly stated and the criteria was met and it was easy to read. The primary reason I found this to be a good study was that it provides relatively easy to read data that can allow a clinician to make their own opinions regardless of the effectiveness of the therapy. I personally didn't find many weaknesses with the study. I felt like it was well-rounded and it touched on all points and there wasn't much bias included. And then basically there was in the summary of the primary literature, Pregabalin provided significantly improved treatment outcomes as compared to with the placebo augmentation rates that was significantly lower than Pregabalin than the 0.5 Pramipexole. Although Pregabalin could have used an alternative and an important contraindication used before switching therapy is a risk for the suicidal ideation. Application and conclusions. This is an important when applying to cost. Knowing the alternative therapy can be used, this can be beneficial to certain patients. Also, when giving doctors certain options and one medication is not covered, it is important to give them significant information backed from studies like this one. Mainly to evaluate your advice and prescribing your reputation as a pharmacist. Excuse me. So with that, I would like to thank you for your time and your undivided attention for these 15 minutes in this journal club assignment. I want to thank you again for your time. My name is Antonio Rayford and have a happy and safe holiday season.